So we come to the next talk. So we change gear a bit. We come back to the more classic approach. And Anna Kosia-Pruchnik from Warsaw, Poland will tell us about EMG and neurography in the setup and assessment of neuromuscular disorders. Anna, please.
Good morning, everyone. It's a pleasure and honor to be here, and I will speak about what is really a classic in the diagnosis of neuromuscular diseases, a classic that is probably not as important as it used to be, but it's not definitely gone yet. Of course, if we view electrophysiological studies as the extension of clinical examination, it may really aid in diagnosis. It's definitely more useful for the adult patients. There is more limited use for pediatric, also because the method is quite painful, uncomfortable for a child, and we also have much better access to other important diagnostic methods that we have already heard about, and we will speak more during this workshop. Of course, electrodiagnostics in neuromuscular diseases has some advantages, but also some limitations. It will really not give us a precise diagnosis, but it might give us good insight into what is the level of lesion, and going through the whole peripheral nervous system. Of course, it starts with motor neuron, SMA, and ALS. Good examples. I will not speak about ALS. That's really a topic for another situation. Peripheral nerve, both for acquired and hereditary neuropathies, of course for neuromuscular junction, and also for some muscle diseases with probably more focus on the acquired ones. What we see during EMG examination, we see different patterns. So again, it is about adding the clinical pattern to the electrophysiological pattern with reinnervation leading to large motor units. In LEMS we have and myasthenia decremental response, and myopathy have small polyphasic brief motor units. Also, the nerve conduction studies can give us a very nice insight into what happens to the motor and sensory nerves, the large myelinated nerves. And of course, we look for either proof of axonal injury, which will be most pronounced in the long nerves, lower extremity nerves more than the upper extremity nerves, for conduction block, which might occur in some hereditary neuropathies, but it's really a hallmark of acquired neuropathies. Focal slowing, very important, but also low compound muscle action potential is possible for some myopathy patients due to reduced muscle mass, so many of our findings will be non-specific. EMG has changed its place in the diagnosis of neuromuscular diseases. The classical pathway will be, of course, a very careful history, including family history, time course, more for acute, subacute than for very long-term pattern of disease development, clinical examination, pattern recognition, distal, proximal, symmetrical, focal, some laboratory tests that our patients may already have done before they came to our office, and then some kind of modality of electrophysiological exam that will depend on what is our primary diagnosis. More often we will go from clinical to EMG tests, but there will be more and more situations when EMG is no longer necessary, may even just delay diagnosis. What are the advantages and limitations of electrophysiological methods? I think that the most important advantage is that results are available immediately during the test. The patient leaves the examination room, and you can already say, okay, this is peripheral nerve or this is neuromuscular junction. We can also monitor disease progression or treatment results. Not always can be replaced with some imaging methods, but there are also some challenges. It's really operator dependent, depends on the protocol that we have, the technique that we apply, and also good reference values are necessary. The limitations, of course, the findings are non-specific. They do not diagnose a disease, just a level of lesion, but often are a part of diagnostic criteria, and this is very important for acquired neuromuscular diseases, especially for the peripheral neuropathies. If we want to have a successful electrodiagnostic test in a neuromuscular patient, of course, the very first question that we should ask ourselves is EMG or nerve conduction study needed at all? Do we have any specific phenotype that will lead to a very precise targeted testing? Or maybe we can apply other methods such as antibody testing that will be also cost effective. What methods to use, what muscles and nerves should be tested, how big should be our examination, and finally, do the findings fit the clinical pattern, because we can find something unexpected or something that will, for instance, show us the double trouble pattern in a patient. And of course, does normal EMG nerve conduction study exclude neuromuscular disease diagnosis? So can we skip EMG or nerve conduction studies? This is something that we've already discussed today, and these are very classical examples. Of course, if the patient is a young boy with a limb girdle weakness, gets up from the floor with Gover's maneuver, no EMG is needed. We go straight to genetic testing, and of course, this will be the boy with Duchenne muscular dystrophy. Also, the patient with such phenotype will not need electrodiagnostic testing, and sometimes we see the patient that could already be saved EMG, but it was done. That's quite a recent story. The boy with limb girdle weakness. As you can see, he gets up from the floor with a very typical pattern. He's 10, he had normal milestones, family history is unremarkable, waddling gait, slowly progressive for the past 5-6 years, absent knee reflexes, finger tremor, CK 4 times upper limit of normal. So was EMG necessary? No, it wasn't, but he was referred for it. It was done anyway, and what we saw was a very typical neurogenic, chronic neurogenic pattern that fits with his clinical history and allows to make a preliminary diagnosis of SMA. But of course, many countries nowadays already employ newborn screening for SMA. Still, we have to remember that approximately 2 to 4% of SMA patients will escape diagnosis with newborn screening, and each of us will still be seeing some patients that need to be diagnosed in a symptomatic time. And I believe that the availability of disease-modifying therapy really calls for targeted testing for SMA just to save time and allow such person to be treated as soon as possible. There are, of course, situations when, in my opinion, EMG or nerve conduction studies are still very important, and there will be just a few examples. So this is a boy that recently came to my office. He will get up from the floor with some difficulties. 18 months old, referred by pediatrician, decreased muscle tone. Parents worried because he's much slower than older brother his age. His milestone was still normal. The family history was not relevant. As you could see, some proximal weakness maybe, but the mother had surgery of her feet in childhood. the boy has decreased muscle tone, absent deep tendon reflexes, it's really easy. But what will be the best next step in your clinical practice? Would we go for the extended examination of the boy? Maybe myopathy NGS panel, CMT NGS panel, or maybe we would rather focus on the mother, and I would really probably do this, and this will definitely save the boy some of the pain, and also will save us quite a lot of time. Of course, this is the boy with CMT 1. This is a different family, this time mother and son. The son is 4 years old, and what we can appreciate is that in the nerve conduction studies, the slowing is homogeneous no matter what nerves we test. It's very similar in upper and lower extremity nerves, and it's quite similar in the case of this family in both generations, being at least 25 years apart. Does it mean that every young child that comes with the myelin-mediating neuropathy does have CMT1A? Of course, there can be some statistics to it. Again, another example of the nerve conduction studies performed this time in a girl with brief story of fluctuating peripheral weakness, mostly on the ulnar side, and that's a classical pattern that we see in hereditary neuropathy with pressure pulses, but the preliminary diagnosis for the girl was in fact CIDP, so this short nerve conduction study with a typical pattern of two slowings at the distal part of a median motor nerve across the elbow of both ulnar nerves really fits with the diagnosis of HNPP. And this is another of our patients, but the boy who had first symptoms when he was just 15 months old. He had normal milestones, slowly progressive course of his motor weakness with proximal distal weakness, absent deep tendon reflexes. He was referred to us for the first time when he was 7 with preliminary CMT diagnosis. He was in fact first seen by a pediatric neurologist when he was 2. A very small EMG showed the myelination, so CMT was diagnosed, but no genetic testing was pursued. No family history. He was referred after stepwise progression. At that time, he was not able to get up from the floor. There were frequent falls, absent deep tendon reflexes. And if we compare it with the pattern seen in CMT1 family, this is really heterogeneous with different degree of nerve conduction slowing in different motor nerves of his upper extremity, 23-30 in median and less than 10 meters per second in ulnar, and also quite a variety in terms of amplitude of his CMAP, and definitely neuropathy is sensory motor. He was diagnosed with CIDP. He made rapid incomplete improvement with corticosteroids and only partial response to IVIGs. At 14 years, he was also diagnosed with diabetes type 1. He's treated with IVIGs, corticosteroids, as the response to IVIGs was not complete, methotrexate, and he still has active CIDP, and there will be the boy nowadays. His exacerbations are more proximal. He's still quite asymmetrical. Unfortunately, there is a lot of axonal degeneration that occurred during those first 5 years before he was able to reach diagnosis, but he's still able to respond to treatment, and he will also show his gait pattern. So he's definitely fixed in his weakness distally, but has a lot of proximal weakness as well. So for chronic inflammatory demyelinating polyneuropathy diagnosis, of course, we have to look for the clinical pattern in terms of chronic progression over at least 8 weeks with progressive or relapsing symmetric proximal and distal muscle weakness of upper and lower limbs, and also sensory involvement at the least 2 limbs. The pattern can be asymmetric. Most of the patients would progress over time to a classical symmetric presentation, but with all the variants that have been described so far, ranging from distal CIDP through multifocal pattern that might start with just single limb, motor CIDP and sensory CIDP, it is really not possible to make the diagnosis without thorough nerve conduction studies where we look for multifocal demyelination. A case of our 60-year-old patient who came with a history of 4 months of walking difficulties. She had also recurrent back pain for the past 3 years, nothing special for a lady in her 60s, well-controlled hypertension. On examination, she had proximal distal paresis, more on the left than the right, absent deep tendon reflexes in her lower extremities, and we, of course, started with EMG. In the nerve conduction studies, and the original EMG focused on the lower extremity nerves according to the symptomatology, there was really nothing. She had normal CMAP amplitude, distal latencies, also the conduction velocities were within normal limits. There were no F-waves abnormalities, also the sensory study was completely normal. Her CK was normal, and also the EMG, the needle EMG, did not really show anything relevant. So there is a good question: is it neuromuscular? Can we really attribute it to something else? We really felt that the pattern is more neuropathic than myopathic, so we extended a nerve conduction study. And as you can see, again, it does not seem to be much in this part of report, but when we look at the duration of CMAP of her right ulnar nerve, it's increased and it already meets the diagnostic criteria for focal demyelination. So it is quite a good argument for CIDP in her. She had increased protein in her CSF, was treated with IVIGs with preliminary diagnosis of purely motor CIDP, and after treatment she made remarkable recovery, but also there was improvement in her neurography pattern, with duration being normal after IVIG course. And another important group of diseases where EMG continues to be an important tool is myasthenia gravis and myasthenic syndromes. Of course, in a patient who has suspected neuromuscular junction disorders, we have a number of different diagnostic methods that can be employed in different order, and differential between acquired MG or Lambert-Eaton myasthenic syndrome or congenital myasthenic syndrome is very important. Antibody testing, electrophysiological testing, ranging from repetitive nerve stimulation test to single fiber EMG, but also ISPAC test that can be done probably in every office, and other that are feasible in the clinical context. In neuromuscular junction diseases, weakness is due to reduced safety factor of the neuromuscular junction. And in fact, our neurophysiological methods look just at this. Single fiber EMG is an excellent method to detect reduced safety factor of the neuromuscular junction. And of course, different distribution of weakness will also have some influence of the choice of the nerves and muscles to be tested in this context, as not only clinically but also neurophysiologically, the neuromuscular junction abnormalities have some, let's say, predilection. It's easier to demonstrate abnormality in the clinically symptomatic or clinically weak muscle. And what is also important is that cooling improves neuromuscular junction. It's not only the ice pack test, but the observation that many of our patients do not tolerate beautiful hot summers very well. Repetitive nerve stimulation test is an old and classical method, but it's still very good for quick demonstration of abnormality and also to differentiate between presynaptic block, like in Lambert-Eaton, and postsynaptic, like in myasthenia gravis. We look for decrement with low frequency stimulation, post-exercise, or improvement during high frequency stimulation. The test is quite technically demanding, but if we see a nice and reproducible decrement, the diagnosis can be done quite with confidence. Single fiber EMG is a technique that allows identification of single action potentials from individual muscle fibers, and the variability in the time when they occur reflects the safety factor of neuromuscular transmission at the individual neuromuscular junctions, so even subclinical abnormalities can be detected. When we employ any of the electrodiagnostic tests in the diagnosis of neuromuscular junction, or myasthenia or myasthenic syndrome patient, we really have to be aware about sensitivity and specificity of the test that we choose. It will really depend on whether we test the proximal or facial muscles, orbicularis oculi muscle being one of the best to be tested, and what is the specificity of the test. On the right side, the ocular myasthenia, on the left, generalized myasthenia, and of course, very good sensitivity for generalized myasthenia patients, but it's really not easy to confirm MG in an ocular patient with repetitive nerve stimulation test alone. And one of the examples that comes from the summer. The summer was beautiful and very hot. 22-year-old lady with motor disability of variable intensity since her teens. She was weaker after exercise. She had sometimes droopy eyelids, no diplopia, has difficulty biting occasionally, no dysphagia. Her old medical records say she had positive repetitive nerve stimulation test, no information what muscle was tested, no information what was the degree of the decremental response. She was double seronegative. She had thymectomy previously with no improvement, treated with prednisone 20 milligram per day, again with no improvement. Pyridostigmine, 2 tablets a day, a low dose, but she does not tolerate higher doses. Currently, really nothing on the neurological examination, so we rely on the history. But when we asked her all the questions that are included in the myasthenia gravis activity of daily life questionnaire, she gained 6 points for eyelids and limbs dysfunction. We repeated laboratory tests, again double seronegative, repetitive nerve stimulation test of the facial muscles, normal, and on single fiber EMG, he had no neuromuscular transmission abnormalities. So the question is, minimal manifestation? No. Still symptomatic. It still has some impact on her everyday activities. She's seeking help, and we have really no clue whatsoever. So the question was, can you please describe your problem in your own words? She's seen many neurologists on the way, and she sort of accepted some of the terms we use or that were used in her medical documentation. So she says, my muscles get weak during exercise. Sometimes they get stiff. Yeah, it's really the stiffness that bothers me the most. My eyelids are drooping, but I feel worse in the cold. The medication I was given didn't help at all. And this is her. And we have challenged her a little with some exercise, and I think you will agree with me that it changes. She's developing some ptosis. And then we put an ice on her eyelid, and it's definitely worse. So it's not myasthenia. In fact, when we performed EMG in her cold muscle, she had myotonic discharges. She had positive short exercise test with cooling, the Fournier method that is quite useful for looking into patients who have episodic symptoms and can be suspected of having muscle channelopathies. And finally, paramyotonia congenita was diagnosed in a lady. She was treated with mexiletin with very good result. So not all the patients with ptosis and some weakness after exertion will be the ones with neuromuscular junction problem. Very briefly about Lambert-Eaton myasthenic syndrome, Lambert triad, again, 1950s, low amplitude CMAP, decremental response with low frequency repetitive nerve stimulation, and increase of the amplitude, or in other words, facilitation after brief voluntary contraction or with high frequency stimulation is the pattern that is typical for presynaptic abnormalities. And we should also remember that for Lambert-Eaton, distal muscles are definitely better. What if repetitive nerve stimulation test is negative in a seronegative patients and we still think it might be myasthenia? Test another weak nerve muscle pair, another nerve muscle pair. Look for orbicularis oculi muscle, proximal limb muscle for MG or distal for Lambert-Eaton, weak if we think it might be congenital myasthenic syndrome patient. Single fiber, very good, with good positive predictive and negative predictive value for MG if orbicularis oculi muscle is tested. And of course, look for alternative diagnosis. So coming close to the end of what I think is still the good place for EMG in neuromuscular patient diagnosis, when would you think that any of the modalities is necessary as a part of diagnostic algorithm? Congenital myopathy, DMD, whenever MG is suspected, I believe in neuropathy patients, even very young ones, especially sporadic cases when we do not have clear-cut information, it is CMT, but definitely, unfortunately, no, fortunately, not always. EMG is still irreplaceable in diagnosing acquired neuropathies. It is important for classification of hereditary neuropathies, but also for testing family members or choosing, in some situations, the right neuromuscular gene panels. Very important for neuromuscular junction patients, especially in the setting of high dynamics when we think the patient needs to be treated. Some additional tests with cooling or exercise might aid diagnosis of some patients with muscle channelopathies. And as always in neuromuscular diseases, it starts with good phenotype description, good electrodiagnostic testing plan, and the experienced team that does the diagnostic workup. Thank you.
Anna, wonderful talk. Before we start with the Q&A, may I ask how many of you have electrophysiology examination or did really a course of electrophysiology? How many of you? Okay, less than a third, so it's quite a bit. And the others are planning to do that? So is this on your list, the wish list to do? You still consider this as a high priority for the younger ones? Some of them? Okay, that's interesting because, well, we are losing ground here. It's really something everywhere around the world that electrophysiology, even in some, if you're educated in the English system, it's completely separated to the neuromuscular world. But in others, it's mixed and still there's a need for it. Even for the infants, we learned it again from Regan that there's still a place for electrophysiology and we should keep it. So it's one of the method parts, like muscle biopsy. We can't lose all of them. Genetics will not, and antibody testing will not give all the results. So therefore, we need a bit more on this, and we need training. You need quite a bit of training to be really such a good electrophysiologist as Anna, of course, is that. Anyhow, questions regarding this? Is there any? I don't see online questions. So people online, please also, you can use the Q&A and...
May I have a two-sentence comment? Of course, EMG is very important for what we do mostly for adults, but nowadays on the right side of the bed in EMG lab, we have EMG machine, and on the left side, ultrasound.
Yes.
So it's really complementary. It's not just about function, it's also about structure.
I fully agree. So this is really the new setting in an outpatient clinic should be EMG and ultrasound, that you have both ways in that. So I don't see there's one question.
Thank you for this great talk. I wonder, what is the diagnostic power of EMG in congenital myasthenic syndromes in very young babies, especially? Because this is difficult to diagnose at that time. We have no antibody test, and genetic test is a little bit late because child is sick. What is your opinion, the diagnostic power of?
Of course, the congenital myasthenic syndrome patients, regardless of age, the vast majority of them would have abnormality of repetitive nerve stimulation test. The older EMG pediatric textbooks, I believe Brown and Bolton said, if you have no idea about why the baby is floppy, do RNS, because this is really something that is treatable. I mean, not always CMS can be treated with a very high effectiveness, but for some of the patients, simple and inexpensive treatment can really make a lot of difference. So I would say that repetitive nerve stimulation test, which is difficult and quite demanding, especially in a very young baby, is still worthwhile because we do not want to miss something that is treatable. And I think it was quite clear in Benedict's talk and all the talks so far. Genetic testing can be available everywhere, but the waiting time for the result is not always that, quick. So my thumbs up for EMG is that we have immediate result. Autoimmune MG in young babies is very, very rare. So I believe we should do it.
No. Any other questions here in the room? So I have one for the room again. Single fiber EMG. So there's, I know only a few experts. Is there anyone around who doing this on a regular basis? Stan. Very good. But this is also super rare nowadays. So even in my center, we hardly do it. So the knowledge there is completely declining, and this could be of interest. Consider EMG and all these things also for treatment. So in the way what we are doing for gene therapy and all these type of things, there might be a role even for electrophysiology coming back, showing earlier change than we see it clinically. So therefore, don't completely forget it, please. Therefore, I'm always say this needs to be part of the teaching course to really get a little flag on this still, that we don't lose it.
And one more comment on the paramyotonia lady that I have presented that was really, labeled as seronegative MG. I didn't mention one thing. Our colleague that did single fiber came back after the examination and said, once when I was changing the position of the needle, there was something, I'm sorry, we look and we listen to the signals from the muscle. It was probably a myotonic discharge, my guess. But of course, it takes cooling to be able to demonstrate it in some of the patients. So we were, let's say, already guided by this observation.
But this could be a clue for our next seminar we do here. Perhaps for the next teaching course, we have a sound seminar. Because I normally don't look at the screen, I just listen to the sound. So that could be very nice. Okay.